Welcome back. I'm super excited to share this next segment with you and the remarkable work that's been going on here. We're going to spend some time now with our friends at Mercy Flights. Mercy Flights is a nonprofit air and ground ambulance service. It was founded back in 1949 by a man named George Milligan. He was an air traffic controller in Medford. And after a friend of his died of polio in Southern Oregon, he was unable to survive the long, slow ground transport to get him to Portland. At the time, that was the inspiration that got Mercy Flights flying. They provide air and ground medical transport while also leading different kinds of programs that improve community health. And they've been phenomenal partners to work with in a lot of different realms, but especially in partnership with pharmacy, our department here at Care Oregon. We'll talk a little bit more about how that partnership works. So to present together for this segment here today, we have from Mercy Flights, Sabrina Ballou. She's the supervisor of Mercy Flights' Mobile Integrated Healthcare Department. Sabrina is a paramedic and community health worker herself, has been with Mercy Flights and in EMS all the way back since 2010. She began as an EMT, responding to 911 calls of the local fire department. Was part of a startup team of Mercy Flights' Mobile Integrated Health Program, focusing on taking patient care to the patient. Sabrina has been instrumental in developing these new programs, rising risk, COVID response, transitions of care, and delivering care during and after the incredibly challenging wildfire in Southern Oregon of 2020. So she's seen a lot. Partnering up with Sabrina today is Care Oregon's very own Nick Kim, one of our pharmacists who's previously worked in biosimilar novel drug research and development. Nick did his PGY1 residency, trained clinical as PharmD, and after training worked at Providence Critical and Acute Care Unit as the clinical pharmacist there. So a ton of experience and collaboration about to reveal itself. Please bring your attention to Sabrina and Nick.
Thanks, Paul. Good morning, everyone. My name is Sabrina Ballou, and I am with Mercy Flights Mobile Integrated Health down in Southern Oregon, and I am joined by Nick Kim, who will be introducing himself just shortly. And we are here today to talk about our unique partnership through Jackson Care Connect and Mercy Flights Mobile Integrated Health. So first, just a little history about us. Mercy Flights is the nation's first non-profit air ambulance service, and it was founded in 1949 by George Milligan. He founded this air ambulance service due to the fact that he was seeing his friends and one of his best friends die from polio due to the long transport from Southern Oregon to Portland. So he created their air ambulance service to get residents from Southern Oregon up to Portland to get the much needed treatment. So we've been in operation since then, and we have an air and ground operations down in Southern Oregon. In 2016, we started our mobile integrated health care services. So a little bit about me. My name is Sabrina Ballou, as I said. I've been a paramedic since 2013, and I've been in EMS since about 2010. Prior to 2013, I was an EMT firefighter locally. And with that, I responded to multiple 911 calls where I noticed there was gaps in services and patients just needed additional help. I've been with Mercy Flights since 2013, and I have been a CHW since 2019. I've also been part of our mobile integrated healthcare team, which we will refer to moving forward as our MIH team, since the start of it in 2016. And I am going to hand this over to Nick, and he's going to introduce himself.
All right, good morning, everyone. My name is Nick Kim. I'm a clinical pharmacist for CPCCO and JCC. Previously worked in a pharmaceutical industry for about 5 years, developing biosimilar and novel product development, mostly involved in worldwide clinical trials and registration. After that, I did my PharmD, and then I got trained PGY1 residency training at Providence St. Mary Medical Center. I took the job there and worked at the clinical and acute care unit as a clinical PharmD. I'm going to take it over to Sabrina for Mercy Flight.
Thanks, Nick. So what is mobile integrated healthcare? Mobile integrated healthcare is all about leveraging EMS to deliver patient care to wherever the patient is. EMS providers have a very unique opportunity to see patients wherever they call home or wherever they're comfortable. We see them in their home, whether it's an actual four walls, a street corner, urban campground, a car, wherever their emergency is. So our whole entire goal is taking patient care back to the patient. So true boots on the ground. One of the very unique thing about our MIH team is we are cross-trained as community health workers. There are programs throughout the United States that have community health workers on their teams, but we are one of the very few that our paramedics are trained as community health workers also. So MIH providers could be multiple disciplinary throughout the state or throughout their team. So they can have EMTs, paramedics, PAs, nurse practitioners, peer support. Everybody's team is made up of different disciplinaries. So the unique thing about an MIH team or community paramedics, you'll hear them interchange differently throughout the US. These teams are built to cater to whatever that community needs. So if a community is running into a significant amount of drug overdoses, they may create a team for that. If they are running into a significant amount of patients that are going to the ER for primary care, they may create a program to address that need. A diabetic, it can go on and on. So what I'm going to do is go ahead and share a little bit about our MIH history. We started researching our MIH program in 2015. We visited other programs throughout the United States, and we launched ours at the beginning of 2016 in partnership with Jackson Care Connect. Our main focus was on high utilizers of either EMS or ED, and we were insurance blind. We worked with all patients of all types, and it didn't matter what they were going to the ED for or calling 911 for. The program was quite successful. We saw a reduction of ED utilization and EMS utilization. So in 2017, our next focus was working on a transition of care. We launched that program mid-2017 with a focus on reducing readmissions and focusing on whole patient health. And that involved meeting patients in the hospital, doing a social determinants assessment, focusing on does the patient have everything they need to discharge from hospital to home, and that could be durable medical equipment. Will they be able to pick up their medications? Do they understand the medications? Do they understand red flags? Do they understand their disease processes? In 2018, we launched our Rising Risk program and on engaged population. And this program focused on a population of patients that were assigned to a clinic, but were using the ED for primary care. And then 2020 happened. That brought on COVID testing and vaccinations, early 2021, the wildfires and natural disasters. And then current in 2021, we have partnerships with FEMA and public health. So as you can see, as I discussed before, these programs can be adapted to whatever the community needs and as time evolves. So currently we still have our transition of care, our rising risk, and then we're still working with FEMA and public health to address the pandemic and natural disasters. I'm not going to cover this too much. There's a lot of people who enjoy data, but we really want to show the success of this programs because I really want to focus on our partnership with Nick and the importance of pharmacy review and patients understanding medications. But back in 2020, we worked with an actuary with Care Oregon who did some wonderful research and showed the return on investment of our work. So they focused on the patients that we had worked with and the ones that declined us. And as you can see, we had quite a big pool of patients. So these are the patients that we worked with. So the graduated patients are underneath the graduated. So most of our patients are the sick of the sick. We have most of them have diabetes, heart failure, pulmonary disease, and then have at least one other chronic condition. So the patients that graduated our program, and what a graduation from our program means is that they have had a home visit, they've gone through a disease process education, they've had a full medication review, thanks to our partnership with Jackson Care Connect and Nick and the pharmacist. And then we have ensured that they have followed up with their PCP and they have everything they need to be successful at home. And then, of course, we've tracked those that declined us. Before I continue on, I'm going to give a bunch of information, and as I go through this, sometimes I talk a little bit fast, but if you have any questions, please feel free to put it in the chat, and we will have a time at the end of this for questions and answers. So what the actuaries were able to find for us is that the work that we have done, we actually were able to connect some of these patients to behavioral health, medical assisted treatment. Most of them, 2,000 of our 19 graduated members had an SUD diagnosis. Of course, 28.2 had some sort of SUD diagnosis. I'm not going to read this all to you, but we can share out these slides later for those that would like to have them. And again, feel free to follow up after this or offline if you guys have more questions. So those that were working with us in our program, they some sort of diagnosis and or addiction, so opioids, stimulants, alcohol, and they graduated with our program. That these patients, when they worked with us, and what I mean by worked with us is that our team members will actually go with the patients to the very first assessment. So they'll go in for the ASAMS assessment at a treatment center, or we will continue work with them and say, hey, are you ready for treatment? If you're not, that's cool. We'll just go whenever you're ready. Or we'll just continually be persistent. One key example is we had a gentleman who he was referred to our program 3 or 4 times before he finally said yes. And 3 or 4 times prior to that, he kindly told me to go away. And when he finally did decide to engage in our program, I said, well, okay, well, finally, what made you change your mind? And he said, well, I didn't think you were serious. I didn't actually think you were actually going to be here for me. And prior to my engagement, he had readmitted into the hospital every month, at least twice a month, and he would be in there for 2 to 3 weeks at a time. So he'd get out, be home for 2 or 3 days, and readmit. And he had COPD, and he used stimulants and alcohol. He was homeless. To this day, he's readmitted once, and that he actually has his own apartment, and he has been clean and sober for 2 years now. So that was the best part about it, is that his best thing is I didn't actually think he'd follow through. So those that worked with our team, as you can see, these are the patients that actually engaged with. And what I mean by that is these patients actually, after graduation or while they're with us, actually started to get treatment. So significant impact on MAT engagement. And so this is all through claims-based data. This is not what we're saying. This is not just our opinion. This is coming from true claims-based data that these patients are receiving treatment and they are being successful in their treatment. So for a patient to be successful and for us to reduce readmissions in the hospital, but most of all for a patient to be successful and for them to engage in their own care and to reduce healthcare costs, to allow them to be healthier, to be able to get out in the community, they need to understand what they're taking. And if they're going to go from taking 30 medications to 20 medications, or if a patient discharges with this huge packet of paperwork and they don't understand a single thing that's happening, or they have all these medications, but I think Nick will be able to talk a little bit more about this later, but they have 3 inhalers, but they don't understand why they need all of them and which one they're supposed to use, they're not going to be successful. So talking about whole patient health is the most important thing. So a recent study done by the Association of Respiratory Care found that 69% of patients were non-compliant with meds post-discharge. 45% of those patients had inadequate knowledge of their medications, and then 42% of those patients were unable to manage their own care. So the goal is to create a complete medication list of supplements and over-the-counter medications across the continuum of care. So one of the key pointers that our team does when we go visit the patient in the home is that we will do a full medication review. And that means we will take the after visit summary from the hospital visit. We will take whatever the doctor that the patient is established with tells us that the patient's supposed to be taken. And then we will actually connect with Nick and the pharmacy team for JCC and Care Oregon and say, okay, have they been able to fill these medications? And then we will follow up with the patient at home. We'll take that huge list, and then we will take the patient's medications out and compare them to them. And the goal is to create an accurate list and ensure the patient understands they know what they're taking. We make a good, solid list for them. We report that back to not only the patient's provider, but also back to the regional care team here in Southern Oregon for JCC. And that's Jackson Care Connect. So with our unique partnership with Jackson Care Connect and our MIH team completes a full medication review prior to visiting the patient in the home. And then once we complete that review, we find out that there is significant discrepancies from the discharge orders to what the patient's actually taken in the home or what the doctor has ordered, or everybody uses a different health record. If one specialist is prescribing something and then the other primary care provider doesn't know, we can actually consolidate all the medications on one form and report that back out, and then come back, consolidate it down, and then we will actually, if needed, go back out to another home visit and ensure that the patient actually fully understands all the medications, there's no interactions. And then the really unique thing is if we are with the patient when we discover this or there's questions, we're really lucky to be able to call in and ask, hey, we've got all these medications, what do we do? Can you walk through this with us? So Nick will be able to talk a little bit about this, but since he started tracking his data, we've actually been able to complete 73 very in-depth, complicated medication reviews since 3/17/2020 to 3/17/2021. So a couple examples of errors that we've avoided with this partnership is one particular example is a patient that was discharged from the hospital with 3 different strengths of prednisone. And this was not for a taper. This patient was prescribed 3 different strengths, quantity of prednisone from 3 different providers within the same hospital system. We were luckily able to see her within 24 hours, I believe, of discharging from the hospital, and she had just started taking her medications, and we were able to stop that before that happened and get her on the right medications. Another example is a patient who, when we went out to go visit them in the home, pulled out their medications, and the provider that he saw during his normal primary care visits, he was taking 1 strength of lisinopril. Then he went and saw a specialist. His specialist gave him another strength of lisinopril. So he was doubling up on his lisinopril. And he's like, well, that probably explains a whole lot of my symptoms. We were able to talk to his cardiologist, make sure that he had the right medications, talk to his primary care provider, and we were all able to get everybody on the same page. So a couple of the measures of success that we have within our own system that we watch is, number 1 is patient education. We have protocols in place for our team to educate our patients on whatever disease process that we have. We complete a full medication review. Our second goal is utilization and reduction. So since the program, and we track our utilization through Collective or pre-manage or EDDI, whichever program you want to call it, but all through Collective. We have a 71% reduction in readmissions going on with the average cost of a readmission is over $9 million. And this is tracking patients, how many admissions they had prior to how many they had after. We had a 48% reduction in ED services, and which is cost reduction of close to $880,000. And then of course, this is utilization for the patients that we track. The other thing is we really want our patients to be engaged in their health and working with their providers to ensure improved patient outcomes. So we've had our patients track their health scores prior to our engagements and after. So we had a 50% increase in overall patient health improvement scores. And then we have increased access to healthcare. So that could be dental, mental health, substance use, abuse treatment, and then housing referrals. So some of our work that we've done in 2020 is our MIH team worked through the emergency of the Alameda and the Aubergine fires down in Southern Oregon, assisting through the evacuations. And then we worked for the months following that by those affected for those that were affected by the wildfires. We delivered food boxes, and then we connected patients to the needed DME, medications, and any other thing they needed to address their health. And then of course, now with the COVID-19, we are working through mobile testing and delivering vaccines to where patients need it the most. So we will take it to wherever they're at in their home, on the street corner. We do in-home vaccinations, drive-through clinic. Today we've provided 3,000 plus vaccines. And now I'm going to let Nick take it away with some patient case successes.
Thank you, Sabrina. Before we go into the handful of patient cases and success story that we were able to achieve over the last couple of years, throughout the collaboration between the Jackson Care Connect pharmacists and MIH of Mercy Flight. I want to briefly mention the beauty of this collaboration is it can only happen due to the fact that MIH has direct access to the patient visits, and also Jackson Care Connect have a database such as pharmacy claim history, the internal nurse having a medical PA availability, and their reports can be shared internally so that we can make quick decision. One example is the last year there was a wildfire and a lot of patients does not have lost access of a medication immediately because they're affected. They just have to evacuate it right away. And we acknowledged the urgency of it. We took that patient seriously, and then we override those medications so that patient can take it right away. These are just handful, but like Sabrina mentioned it, we have a Q&A session at the end of this presentation, so please feel free to share with us. So I'm going to go back to the patient case number 1. MC is 31-year-old history of multiple sclerosis and came to the ED with the 9-day history of vision loss. Patient was diagnosed with the MS flare exacerbation, and ED gave a gram of solumetrol. This patient was referred to me the day prior to the Mercy Flight Jackson Care Connect huddles on 8/9/2020. The medications and the medical record, the EMR were reviewed thoroughly. And also upon the medical record review, the patient was stated that after 3 days of solumetrol, he's left-hand and his vision is not improving. That's why we took this case seriously and did an internal consult with the medical director and clinical pharmacy supervisor, and concluded that we are going to refer this patient to OHSU neurology. Mercy Flight MIH facilitated care by obtaining a referral from the patient PCP, and we were able to bring the patient to the up-bed OHSU as soon as possible. And going into the next case, this is patient case number 2. AO is a 35-year-old male with a history of hypertension, alcohol abuse. Most patients' ED utilization was due to the alcohol intoxication. So A was referred to me also the day prior to the huddle, on 2/4 this year, 2021. His medication and medical record review, and the case was assigned to the behavioral health care coordinator and assessed the needs of assistant of housing and dental behavioral health support. We also have a JCC member that speaks Spanish, and because AO is a Spanish-speaking member, we were able to get a help from this Spanish-speaking JCC staff, and he was able to get him connected to the dental and FEMA to get the housing support. MF, the Mercy Flights, MIH requested help with the TransLink, needing more time to get PCP appointment documentation of his disability. JCC staff reached out to the TransLink, and then they were able to approve an extra month to get the documentation in. These are also some of our success story. The patient recently discharged from the state at SNF with a 36 different medication. In home visit with the MIH provider, they identify some needs to be looked at by the JCC pharmacist. So I took a look at it and found a lot of duplicate medication. So we were able to reduce the number of medication down to 17. Another success case, 41-year-old male, houseless, with a history of traumatic brain injury and seizure disorder. MIH evaluated and discovered his heart rate was at 40s. And he was admitted and stabilized with the combined effort of MIH and JCC pharmacists and local urban campground. We were able to get in his medication and into the safe place. All right, this is all the story that we are prepared for this presentation, but we do have more stories. So if you are curious to learn about in details what other success story, I'm more than happy to share with you offline or Q&A section. I'm going to turn it back to Sabrina.
Thanks, Nick. So I could go on and on. I absolutely love talking about this. So the idea of MIH or community paramedicine has been alive and well in the US probably since about 1997. It is going strong throughout the world. The options are endless. What you can do in your community is absolutely crazy. I mean, you can leverage your EMS system if they're interested and willing, which I can almost guarantee you they are, and if they're not already doing it, to address and work with your patient population. And the very cool part about it is we are not tied by the patient needing to meet homebound status. We go and meet with patients. We have an area through our town. It's called the Greenway. So it's where a lot of our homeless population lives. And we will go meet with them. We work really closely with our local police force to work with patients that are on the Greenway or are needing to be intervened. We have a very unique police team that will actually is trying to navigate a lot of our population down here into housing and just really establish them with care. And so we work really closely alongside them. We have an urban campground that is actually expanding on a regular basis. And so we work alongside them to help get patients transition from the urban campground into the retreat to, and then on and on and on. And it's been a very successful partnership. MIH can just be implemented in your community for whatever the need may be. So we have our looking towards the future here. So this could be clinical partnerships, as our team has actually been able to take our iPads out and take home or telehealth to a patient that's on the Greenway that didn't want to leave their tent site just due to, they didn't want their belongings to be stolen, and he had recently broke his arm. And we were actually able to take the doctor to the patient, provide all the vitals. We were able to get his medications filled, and he didn't have to leave his tent site. He was evaluated, and we didn't have to have him transported to the hospital for an old injury. We were able, there's programs that can do labs on scene mobile care management. You can do sample collection, vaccines, which we're doing currently, monitor in place, such as doing a lab draw, working to give medication to keep a patient at home, especially as our hospitals are reaching max capacity right now, diagnostic testing, mobile case management, social determinants navigator, innovations, care models. And then along with those lines, a lot of programs, even if they're not cross-trained as community health workers, they can work alongside community health workers. There's a program up in Umatilla. They actually work right alongside community health workers. So the community paramedic will go out and the CHW will go alongside with her. So if you would like to know more about this, please don't hesitate to reach out or ask questions. We're going to have Q&A right after this, or connect with me offline. And I look forward to more questions, and I will try not to take more of your time because I could go on and on about this.